name is Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis, where I'm a professor of radiation oncology, director of clinical trials, and chief of the cardiothoracic and stereotactic radiation services. If you've been diagnosed with small cell lung cancer and received a course of chemotherapy and possibly radiation as well, depending on how you're doing overall, your doctor may talk to you about a form of radiation called prophylactic cranial irradiation, or PCI. Prophylactic cranial irradiation is kind of a funny term, and it's a little bit confusing to understand why we're doing it. So let me just take a moment to explain the rationale. First of all, in small cell lung cancer, almost 70% of patients will ultimately develop brain metastases. There's something unique about small cell lung cancer that really likes to travel to the brain. And what we have seen in prior studies is that when we give chemotherapy alone or chemotherapy with radiation to the chest and we do nothing else, a large percentage of patients will then, despite being cured from the neck down, develop brain metastases. Now, there have been a number of things that have been tried over the years, but one of the most successful is to give a series of 5 to 10 low doses of radiation to the brain. Now, when you give radiation to the brain, it doesn't prevent the brain metastases from showing up there and spreading there. What it's doing is potentially ridding the brain of any microscopic tumor cells that you cannot otherwise see on a CT or an MRI. That's because those tests just can't see microscopic small deposits of cells. You might also question why you need to give radiation at all if you've just gotten chemotherapy, and it's because the chemotherapy really gets into the brain in insufficient quantities to sterilize or remove those microscopic tumor cells. There's a barrier between the brain and the blood called the blood-brain barrier that prevents that. So there have been multiple large randomized clinical trials that have shown that in patients who get prophylactic cranial radiation, they have substantially reduced risk of developing brain metastases that grow after being well treated to the chest. And there's a small improvement in survival as well. Now, one of the concerns with prophylactic cranial radiation, as with whole brain radiation treatment in patients who have known brain metastases, is that it may in fact cause injury itself or injury to the brain because of the treatment. We have a lot of data about this, and we know a lot of things about the effect of prophylactic cranial radiation on the brain. When you look at studies where we've taken patients who have received extensive neurologic testing before and afterwards, which is not common during regular clinical care, but is done on studies, we know that it does not affect your overall thinking or functioning, your ability to make decisions, your intelligence, or your long-term memories. However, PCI has been associated with a reduced ability to have short-term memory. Now, what do I mean by that? A good test of this is the shopping list test. A shopping list test is where you are asked to take a series of items, and I might tell you to go to the store and remember to get an apple, an orange, a banana, and grapes. And then later on, I'm going to ask you that same thing 5 minutes later. Now, if you're having any issues with your short-term memory, you would have some difficulty remembering 5 to 10 minutes later what that list was, in which case it might be better for you to write it down. And in fact, that's the type of injury we're talking about that can occur with PCI. Overall, around 30 to 40% of patients who get PCI could expect to have this type of injury. There are a number of different things that can be done to try and avoid this. One is with the use of a medication called memantine or Namenda. Now, while this hasn't specifically been trialed in the prophylactic cranial radiation, it has been trialed in patients receiving whole brain radiation for brain metastases. And the doses and overall technique are roughly similar, so many people extrapolate and say that that's okay to do. That medication is typically given once or twice a day, depending on the formulation, and it's well tolerated in most patients, and it seems to reduce the chances of developing some issues with that short-term memory. The second thing that you can do is something called hippocampal avoidance. This is a more complicated form of radiation that not all clinics are capable of doing today, but is becoming increasingly more popular and easier to do. This involves giving special radiation that avoids the other side of the brain called the hippocampus, which is responsible for processing that short-term memory and putting it into long-term memory. This was just recently tested in a large clinical trial, and the results will be reported shortly, But if it's anything like we've seen in other situations, we expect that this will very likely reduce the risk of neurologic toxicity. And in fact, it has been shown in smaller studies to do so as well. So certainly ask your doctor about that possibility for you as well if you're getting PCI. The last thing is whether or not PCI is required for all patients. So I discussed that it's a common thing to give if you've had chemotherapy and radiation and you're doing well, and we want to reduce the risk of developing brain metastases that grow and cause harm. However, in an era of modern imaging, where we have high-resolution brain MRIs, and in an era where we have increasing use of things like immunotherapy, which seems to also reduce the risk of developing these brain metastases in patients with small cell, is it really necessary to continue to give PCI? The answer is we don't know. And so you have to have the discussion on a patient-by-patient basis. However, there is a large randomized trial asking this question again. The Maverick trial is a trial that's looking at this in patients, perhaps just like you, examining whether or not it may be appropriate to just follow with MRIs and treat at the time of growth, or giving this radiation up front.